few minutes by these headings, a few points about the epidemiology, your pathogenesis of the lupus, clinical manifestations, what is the clinical course of the lupus, diagnostic criteria, and if time permits, a few words on the management also. So as you know that SLE is a very chronic disease, a multi-system disease. It's a big autoimmune disease. Unfortunately, it affects mostly the young women, a reproductive age group, somewhere between 15 to 45 years of the age group. Any organ of the body may be involved, whether it could be lupus nephritis, or brain lupus, or psychiatric lupus, or hemolytic anemias, or pleurosis, pericarditis. You name any organ in the body, the lupus will be there. And the disease is characterized by the remissions and exacerbations like any other autoimmune diseases. You will have the flares where you have to treat with high dose of the steroids like methylprednisolone, maybe 1 gram or the 500 milligrams once a day for 3 days or 5 days. Or sometimes you have to use the cyclophosphamide as the pulse therapy when the disease is in the flare. And the disease in the remissions, you need to treat with hydroxychloroquine or the low dose of the steroids for a longer period so that we can give a good quality of the life and we can prolong the life of the lupus also. With the good management, the 10-year survival may be over the 90%. That's a good thing to know that, because if you see the 2 decades or the 3 decades earlier, the patients present with the lupus, we diagnose at the late stages of the diagnosed disease, and by the time we diagnose the lupus, the patient already in the multi-system disease, very little can be done, and the mortality is the rule, like any other stage 4 carcinoma. But thanks to your area profiles and your vigilance and your understanding about the rheumatology, now we are diagnosing the lupus in the early stages so that we can treat this disease and can give the good quality of the life and we can prolong the life and with a very, very reduced mortality and the morbidity. You all know what we mean by the autoimmunity. These are all the diseases which the pathology is caused by adaptive immune responses to the self-antigens are called the autoimmune diseases. The human immune system recognizes parts of the body as the harmful antigens, so builds a response targeting the self cells. It is very complex. Many different autoimmune diseases, each affecting the body in vastly the different ways. You know the rheumatoid arthritis, it involves the hands, the small joints, and you know the SLE, commonly it involves the kidneys, and you have the systemic sclerosis, it commonly involves the gastrointestinal system, and you have the mixed connectivity disorders, it commonly involves the dermatological lesions and also the neurological lesions. So in that way, even bamboo spine or ankylosing spondylitis, that involves the axial skeleton. So the different autoimmune diseases, they affect the different tissues, but finally if left untreated, and most of these diseases are almost involves the multi-organs. Even the patients with the same autoimmune disease may show the different symptoms. So this year the lupus, they may present like the skin and subcutaneous tissues or your gastrointestinal symptoms. And after the 2 years or the 3 years, that may present like the respiratory symptoms. And after 2 or 3 years, it may present like your pericarditis and etc. So the same disease will present in the multiple systems as in due course. As I told you, this mostly affects the women of the childbearing age. There is a clear evidence of the genetic factors and environmental. See, 2/3 of the cause is the genetics, and the 1/3 of the cause is the environmental factors. There are a lot of the environmental factors like your smoking, your silica exposure, or your hormonal therapy, or some viruses like Epstein-Barr virus, or cytomegalovirus, etc. So these are all the environmental factors, but they are only the 33%, and nearly 2/3 of the cause is the genetical background. These are the lifelong conditions, so we need the treatment. We need to give the treatment for the lifelong, like for any diabetes or the hypertension or the CKD. They need the lifelong treatment, especially with the low dose steroids or a 200 mg or the 300 mg of your hydroxychloroquine. The medication, the treatments can make the quality of the life better for the patients. See, this already I told you the genetic factors, and you can't change our parents, so the genes are there. So this is very common in our Asians, lupus. It's a very common in zygotic twins, and also the environmental factors already I told you, like ultraviolet light, more in the females, some infections, some HPV and etc. And if you see the abnormal immune response, that the cells involved here are the B cells and the T cells. They cause autoantibodies, and your complement levels like C3 and the C4 levels are at a lowered. So by the combination of these antibodies and immune complexes on one hand, and the reduced complements on the other hand, will lead to the tissue damage, and definitely lot of the organs will be involved here. So as far as the skin and dermatology is concerned, some rash is there, malar rash, discoid rash, oral ulcers, nasal ulcers, etc. I will tell you at a later time. And finally, the damage of the different organs. The vessels are very, very important. The lupus vasculitis, antiphospholipid syndrome, and the lupus nephritis, the deadly diseases, and very easily to diagnose. And if you diagnose at the right time, and if you plan for the kidney biopsy, suppose if they need any indication for the kidney biopsy, so definitely we know the disease, nephritis as the stage 1 or 2 or 3 or 4 or 5 to 6, and then act accordingly. So these are the different autoantibodies directed to the cells, the bone marrow. So you all know that autoimmune hemolytic anemias, thrombocytopenia, leukopenia, lymphopenia, these are so common in the lupus. So we have to respect the CBP and also the bone marrow examination here, and also the platelets. Thrombocytopenia is a rule in most of the lupus patients. If you see the peripheral picture, so definitely reduced platelet count, reduced WBC, etc. And clotting factors are also very important in these populations. So ANA is a very important investigation in all the lupus population, but not all ANA positives are having the disease. So simply having the ANA positive doesn't mean that the patient is suffering with the lupus. So if you take the 100 cases of the ANA positivity, maybe 5 to 10% of the lupus patients. On the other hand, if you see the 100 cases of the lupus, 100 are positive with the ANA. So that means negative ANA, we are ruling out the lupus, and positive ANA, most probably the lupus, not diagnostic of the lupus. See that the different lupus are there, the low SLE, ANA positivity. Sometimes, very rarely, maybe ANA negative lupus is also there, and the drug-induced lupus, and then where the histone antibodies will be the positive. So these are the things. So ANA is very, very important. As I told you, the sensitivity is very, very high, but the specificity is not that high. So the ANA, double stranded DNA is a very important investigation to be done in all the ANA positive individuals. Double stranded DNA, anti-SM antibodies, anti-RNP antibodies, anti-Rho, anti-La, etc., and anti-ribosomal antibodies. By noting these antibodies, you can think that these people are more prone for the lupus, more prone for the lupus, more prone for the neuropsychiatric lupus, etc. For example, if the people are having the ribosomal antibodies, so definitely the neuropsychiatric lupus is very common in them. So what I mean to say is ANA positive is not sufficient to diagnose the lupus. You can suspect the lupus, but double-stranded DNA, anti-SM, UN, RNP, etc., they are very much needed to diagnose the lupus. So the common lupus symptoms are the many. So most important is the fatigue, easy fatigability, and low-grade fever. So for all the PUOs, so lupus is the one cause. So you know that the PUO discussions or the investigations of the PUO, definitely we send the blood for the ANA profile, because autoimmune disease is also very, very important as a part and parcel of your PUO workup. And all organs will be involved here. If you see the brain, they will have the vasculitis. So you have the CVA, and you have the headache, unexplained headaches, and also focal convulsions or grand mal epilepsy, etc. So what are all the diseases in the brain that will be caused by your lupus? And mouth and the nose are very important organs to be seen, especially the face. So alopecia is very common. Nasal ulcers are common, nasopharyngeal ulcers are common, oral ulcers are common. So, but they are all painless ulcers, unlike your aphthous ulcers, which are painful. And lungs and heart are very important. The pleuritis or pleurisy or shaking lung syndromes or pulmonary hypertensions or pneumonial infections, etc., are very common. And finger, toes, or the tips of the nose may be turned white or the blue. That is your Raynaud's phenomenon. And unexplained fatigability and the fevers, eyes, dry eyes, puffy eyes, etc. Your jaw grunts maybe could be one of the DDs here. So butterfly rash, your nasolabial fold will be spared in lupus against your dermatomyositis, where nasolabial fold is not spared there. And the stomach is concerned, you have the nausea, you have the vomiting, so pseudo-intestinal obstruction, mesenteric vasculitis. So a lot of the organs in the abdomen also could be involved in the lupus. So in a single word, each and every part in our body will be involved in the lupus. That is the reason it's a very, very, very deadly disease, lupus. It is an index case about a 26-year-old female presented with a generalized fatigue, pain, swelling of the hands, knees and the feet with a morning stiffness of 60 minutes of 5 weeks duration associated with the photosensitive skin rash. So what is your working diagnosis here? With history alone. So young female, a reproductive age group, generalized fatigue, and then arthralgia of your hands, knees and the feet. So both the small joints as well as the large joints are involved here. And morning stiffness of 60 minutes, that shows the inflammatory pains and photosensitive skin rash. So most probably you are dealing a case of the lupus. Not that my discussion is on the lupus, but here is a generalized fatigue and arthralgia, morning stiffness, inflammatory nature and the photosensitive skin rash. Coming to the examination. So with the history alone, 80 to 90% you should suspect the lupus in this case, and examination will give you some clues. So there is an arthritis of the small joints of the hands and the knees and the facial rash is there. Lab, see the lab points. ESR is 70, high elevated. Hemoglobin 11.5 is no more, it's not low, but mostly the normal. WBC is 4.2, it is also normal. Lymphocytes are low, platelets are the normal. Urine proteinuria and the CAS and the microscope. So in all the lupus, whenever you suspect the lupus, you please concentrate the urine examination. Not your proteins and the glucose, but you have to concentrate on the hematuria and the CAS. So when there is an hematuria, when there is more the CAS, that shows the kidney is involved in this lupus. So that means lupus nephritis. Here you have to treat aggressively with your methylprednisones or with your cyclophosphamates, etc. or your azathioprine or cyclosporin, etc. So in this patient, at this juncture, so the patient is having the fewer things, and then the lab shows clearly the patient is in the nephritis. See, so simple. At the 26 years old girl, a female, now the lupus and also the nephritis. You can imagine the quality of the life in here, and also the lifespan also will be reduced, provided if you don't give much importance to this proteinuria and CAS and the microscope. See here, the concentrate on the nasolabial fold. So the butterfly rash, nasolabial folds are spared here. So inflammatory polyarthritis, malar rash and proteinuria. So the most important is the proteinuria point has to tell. So as a physician, so you should identify the diseases at the right time. Otherwise, you also will behave like a general practitioner. You give some NSAIDs or some steroids for your polyarthritis rash. And if you forget the proteinuria, these fellows will end up with elevated creatinine levels, etc. and early dialysis, and they are maybe posted for the transplantation. And you know the renal replacement therapy is very, very difficult in our areas. So these are the common sites for the lupus skin rash. Most important is the face and also the neck and the upper chest and the hands. Hands for your vasculitis picture, hands for your Raynaud's phenomenon, and the head for your alopecia and your oral ulcers, nasal ulcers, nasolabial folds, malar rash, discoid rash, etc. So this is the malar rash, a constant red rash over the cheekbones. Discoid rash is nothing but the raised patches. Photosensitivity is very, very common in this population. Oral ulcers, nasopharyngeal ulcers, etc. But they are painless. See the different pictures of the malar rash. This is the discoid rash, raised patches. Alopecia is very common. Eruptions, painless ulcers, Raynaud's phenomenon. See the deadly vasculitis. So again, these patients you should treat very aggressively. So vasculitis means almost all the vessels in the body. So it could be mesenteric vasculitis, it could be your pulmonary vasculitis, it may be your carotid arteries or coronary arteries, premature atherosclerosis, ischemic heart diseases. So I definitely have to treat very aggressively these population with the steroids, etc. So here the arthritis of the lupus is not like your rheumatoid arthritis. See, the rheumatoid arthritis is an erosive arthritis, whereas the lupus arthritis is not an erosive. The the word given here is the Jacob's arthropathy. They do not cause the deformity of the joints. The swelling of the tenderness must be present. Most frequent involved joints are those of the hands, wrist, and the knees. Muscle involvement was reported in the 30 to 50% of the lupus patients. So the muscle involvement also will be here. So in the rheumatology, so wherever there is there, you have to concentrate not only on the joints, but also the tendons, the ligaments, the bursa, tendina, muscles, etc. So your enthesitis, your bursitis, your tendinitis, etc., dactylitis. So these are also very important to rule out the different autoimmune diseases or different pathological diseases. So as I told you that this is the Jacob's arthropathy, it's a non-erosive arthropathy with a morning stiffness, avascular necrosis. So I have seen a lot of the cases post-COVID, avascular necrosis. This is also very common in the lupus population. Arthritis is usually bilateral, hands, wrist, and knees involved, swan neck deformities, ulnar deviation, subluxation, hyperexcellity. But if you take an X-ray, looks normal, unlike your rheumatoid arthritis where there is an erosions and the destructions. See the X-ray, except the ulnar deviation, you don't find any abnormalities in these pictures. Suppose it was to be a rheumatoid arthritis, so there should be a lot of destruction in these joints. So this is the avascular necrosis. So it's a very common. So one should suspect. So definitely the people with the backache, the people with the pain in the hip region, the people getting the pain and walking and difficult to get up from the sitting position, please suspect the avascular necrosis and then act accordingly. Pulmonary manifestations, fluorosis is so common in lupus, is the most common manifestation. The volume of the pleural effusions usually the mild but to moderate, not very severe, maybe unilateral, sometimes bilateral. Large effusions are very uncommon. It usually exudates in the character. But not only the lupus alone, sometimes it may be because of your nephrotics, maybe because of the secondary infection, or maybe because of the cardiac failure. So not all the fluorosis or pleural effusion in the lupus are because of the lupus origin. Sometimes it could be from the cardiac failure or the nephrotics or from the infections. You should suspect. Pneumonitis is so common because these people are immunologically very weak population. So a lot of the bacterial infections, lung, viral infections, fungal infections, there is they may attack your lungs, so they cause the pneumonitis. So definitely you have to check a CT X-rays and also sputum for culture and sensitivities, etc. and act accordingly. So these people, so not only your pneumonitis, the most important thing is your alveolar hemorrhage. So common in the lupus individuals, the pulmonary hemorrhage and also the pulmonary hypertension. So that is also very common in the lupus individuals and chronic diffuse interstitial lung disease. So this is so common in the lupus individuals. It's very difficult to diagnose interstitial lung disease. So interstitial lung disease because of your lupus or sometimes maybe because of these infections like your viral pneumonias, tuberculosis, bacterial, fungal, etc. or pneumocystis carinii. Because this is very important clinical point to be looked for. The diagnosis because of the infections, you use a lot of the antibiotics, you don't give the steroids. Suppose if the diagnosis is the interstitial lung disease, you have to give the large amounts of the steroids. So in the absence of the interstitial lung disease, if you use the high doses of the steroids, so definitely all these infections will flare up and later the patient will die of sepsis. So on the other hand, if you don't diagnose the interstitial lung disease and you have to initiate on the on the steroid therapy, again the patient is going to sink. So this is a very important point as far as the lung is concerned. In the heart, all the three layers will be involved, not only the pericarditis, myocarditis and endocarditis, Lehmann-Sachs endocarditis, etc. Pericarditis is so common in the lupus population. So pericarditis is pericardial effusions. Myocarditis, sometimes it looks like a viral myocarditis. In not only the viral myocarditis like picture, but most of these lupus individuals, they may present like early ischemic heart disease. So young strokes or young IHD. So definitely you have to suspect young females. So you have to suspect the underground lupus in those individuals. Lehmann-Sachs endocarditis and the valvular diseases like your mitral regurgitations or aortic regurgitations are very common. Hypertension may be because of the three reasons. One is your essential hypertension occurring in this age group because a strong family history of the hypertension in a lupus female. So probably she developed the essential hypertension. And the two other reasons to cause the hypertension in this lupus is your steroid therapy. We use large doses of the steroids here, maybe 1 or 1.5 or the 2 milligrams per kg body weight of your prednisolone, not for 5 days or the 10 days, maybe 6 months, 7 months, 1 year, etc. So the steroid-induced hypertension is the cause. And the third important cause to cause the hypertension in the lupus individuals is obviously your lupus nephritis. So the lupus nephritis causing hypertension or steroid therapy causing hypertension or a strong family history essential hypertension, you should understand and should diagnose because the treatment varies. If it is renal hypertension, so definitely you have to use the lot of the drugs like your calcium channel blockers, your alpha blockers, or central acting drugs, etc. If it is essential hypertension, you can use your ARBs or your chlorothalidone, etc. Cardiac failure is so common in the lupus individuals because it causes pericarditis, it causes myocarditis, and also endocarditis. So this is the Liebman-Sachs endocarditis in which there are flat, reddish, tan vegetations spreading over the mitral valve and the cardiac. Usually these vegetations will be missed by your routine 2D. So when you are suspecting the endocarditis in these individuals, you ask the cardiologist, go for the transthoracic, not only the transthoracic, maybe the transesophageal, echo, then only you can identify these vegetations. Otherwise, you are going to miss the vegetations if you get the report by 2D echo alone. So this is the lupus nephritis, the hypertension, the new onset, the peripheral edema, the weight gain, renal insufficiency, or the failure because of the elevated creatinine levels and asymptomatic urinary findings. This is the very important. Like your proteinuria, your CAS, your hematuria, etc. So this already I told the class 1, class 2. I think the class 1 is the mesangial, mild. Class 2 is the mesangial proliferative. Minimal mesangial is the class 1. Mesangial proliferative is the class 2. And class 3 is the focal. Class 4 is the diffuse. And class 5 is the membranous. And class 6 is, I think, aggressive and the sclerotic, advanced sclerotic. So these are the different things. And definitely you have to respect the pathologist here. So as far as the physician is concerned, even though we are the kings of all the branches, we have to respect the pathology population, we have to respect the microbiologists, we have to respect the radiologists, we have to respect the biochemistry population because they are doing a lot of work for us. So we are the heroes on the screen, but behind the screen, they are the very, very important population. So please respect them. The neuropsychiatric syndromes are very, very common in the lupus individual. They almost behave like your schizophrenia. They almost behave like your manic mania depressive or bipolar diseases because they have the acute confusional state, anxiety disorders, aseptic meningitis, cerebrovascular diseases, cognitive dysfunction, demyelinating syndromes, headaches, mood disorders, movement disorders, myelopathies, psychosis, seizures, either the focal or the generalized. See the CNS involvement. So, lot of the things are there in the lupus individual. See, sometimes we see the patient in a psychiatric behavior. So, the parents, their parents brought to us, so with a psychiatric abnormality, so definitely without seeing the patient, without asking the history, so don't give a referral to your psychiatrist. It could be a lupus, neuropsychiatric lupus. So, that is a very, very important thing. And of course, the peripheral nervous system, you all know that autonomic neuropathies, it's very difficult. There is no single test to diagnose autonomic neuropathy. It's only your suspicion. And cranial neuropathy, obviously, you can diagnose it by seeing the patient. Guillain-Barré syndrome, mononeuropathies, myasthenia gravis, plexopathy, polyneuropathy. They are very common peripheral nervous diseases we often see in the lupus individuals. So, to respect the peripheral smear examination, the red blood cells, the normocytic normochromic of any chronic disease, you can find it. But in India, usually we see the microcytic hypochromic. So you will have the MCV less than the 80, you will have the MCH, MCV, etc. They are the lower, and also your PCV will be the lower, maybe 20 or 15, 18, and your RBC count also maybe the 2 millions or 3 millions, etc. So these are all very important. And the direct Coombs test is also positive in these individuals. Platelets, there will be the thrombocytopenia. White blood cells, don't introduce the platelets therapy in all the lupus individuals unless the platelet count is less than the 10,000 or less than the 20,000 with the bleeding tendencies. So WBC, you will have the leukopenia. Here the point very clear that when the fellow's WBC is very, very low, there are the high chances of getting the inflammations or infections. On the other hand, when the WBC count is very high, so possibly you are dealing a case of the infection, secondary infection in a lupus individual. So the more the WBC count, so definitely you have to introduce the more and more antibiotics there. Gastrointestinal, the motility disorders are very common in the lupus individuals. Intestinal pseudo obstruction is very important. Pancreatitis is important. Lupus hepatitis is important. What is most important here is the protein losing enteropathy. So in the lupus individuals, they keep on losing the protein. So definitely if you see the serum proteins, they will be always lower, and then there will be the reversed albumin to globulin ratio also very same. And mesenteric vasculitis is also very common in the lupus individuals. So this is the vasculitis. You have seen a lot of the inflammatory cells. See, there is a deep vein thrombosis. Again, very common in the lupus individuals. There is no specific test to diagnose the lupus. Lupus is diagnosed primarily on the history, on the physical examination, and sometimes a laboratory investigation like your ANA positive, need not be always the lupus, but negative, you are ruling out the lupus. And then the double standard DNA, etc., SM antibodies, UN RNPs, anti-ribosomal antibodies. These are very common. So elevated serum creatinine levels. Serology, I already discussed something about the complement levels also will be lower. Anti-nuclear antibodies. X-rays, your CT chest is important, X-ray abdomen is important. CT brain, MRI brain, echo, LP, renal biopsy. So what are the indications for the renal biopsy in the lupus? I think there are 3 or 4 indications to get the renal biopsy. One, when the protein level, urine protein level is more than the 1 gram, so definitely you have to go for the biopsy. On the other hand, even though the protein, 24 hours protein is less than the 1 gram, maybe the 500 milligrams, but still, if there is an immaturity of the CAS, again go for the biopsy. And the third important indication here is elevated creatinine levels, not substantiated with any other cause. So what was the cause for this elevated creatinine levels? All these years, the normal creatinine level is the normal, but the last 3 months or the 6 months, creatinine level is going up very speedily. So definitely you need a biopsy. So here there are indications to go for the renal biopsy. So all of you know the SOAP brain MD, the mnemonic, American College of Rheumatology, ACR. They given way back in 1997, I think. So they have given the 14 criteria, 4 out of the 11 criteria, sorry. 4 out of the 11 criteria, you are damn sure that you are dealing a case of the lupus. So SOAP brain MD, S stands for your serositis, O stands for your oral ulcers, A stands for your arthralgia, P stands for your photosensitivity, B stands for your blood examination, your thrombocytopenia, leukopenia, etc. R stands for your renal involvements like proteinuria, elevated, etc. A stands for your ANA positivity. I stands for your immunological reactions like your double standard DNA, etc. N stands for your neuropsychiatric abnormalities, and M is malar rash, and D is the discoid rash. So by noting this SOAP brain MD, so you can identify a case of lupus, but this is outdated. Way back in 1997 they have given, but still very popular among all of us. So the differential diagnosis in rheumatology is so easy. So whenever you see a rheumatoid arthritis, what is the DD? All rheumatological conditions. If you see a case of the lupus, what are the DD? All rheumatological conditions. If you see a case of the gouty polyarthritis, what are the DD? All rheumatological conditions. So you can see what are all the rheumatological conditions. You have to divide. So rheumatoid arthritis mostly small joint involvement, rheumatoid nodules, rheumatoid factor positivity, anti-CCP positivity, etc. And mixed connective tissue disorder, drug-induced lupus, etc. So the genes environment, the preclinical, clinical time definitely, so you can compute a reasonable diagnosis of the lupus. And comorbidities are very important. See, unfortunately in India, a lot of the comorbidities in our young females in the age group of the 30 or the 40 or the less than the 50 years age group. So in this age group, incidence of the diabetes is so common, incidence of the hypertension is so common, incidence of the CKD is common, incidence of IH is very common, incidence of metabolic syndrome, your MS, modern MS is so common in this age group, especially the post deliveries. So a lot of these people become obese and finally they end up with the MS. So the treatment plans are based on the patient's age, sex, health symptoms and lifestyle, and on the disease and the severity. The goals of the treatment: prevent the flares, that is the most important goal. Treat the flares when they occur with your intensive steroid therapy, and minimize the organ damage and the complications by looking for the biopsies at the right time, and the treat with the particular drugs like your mycophenolate mofetil, MMF, or your the cyclosporin, etc. So these are all the important drugs. The steroids are very, very important drugs. So without the steroid, the treatment of the rheumatology is a big zero. Hydroxychloroquine is very, very important drug. Low dose aspirin. So definitely when the failures in the vasculitis, so definitely we need low dose aspirin. Off label, azathioprine maybe 25 mg or the 50 mg, especially when it involves in the lung involvement, especially in the interstitial lung disease. Who use azathioprine? Available in the brand name of SR, maybe 25 mg to be starting dose and 50 mg as the maintenance dose. Cyclophosphamide, we has the pulse therapy 1 gram. NSAIDs of any of your choice, but unfortunately better to use the COX-2 inhibitors in the lupus individuals other than your aceclofenac, etc. So celecoxib is the favorite NSAID of your choice in the lupus individuals because you have the advantage of the COX-2 inhibitors when compared to the protein NSAIDs. They inhibit both the COX-1 and the COX-2. So immunosuppressives, the mycophenolate mofetil is very available in India. We are writing left and right. Cyclosporin is very useful. Tacrolimus sometimes. Methotrexate. So big thanks to our Elaprade Subbarao. So very good drug, methotrexate. A pulse therapy. Maybe 7.5 mg or maybe 5 mg or 10 mg, 15 mg, 20 mg, 25 mg. So somewhere between 5 to 25 mg once in a week. Please use the methotrexate provided if the patient is having the arthralgial spot. So along with the methotrexate, you have to use the folic acid, again invented by the Elaprade Subbarao. So use the folic acid along with the methotrexate, maybe 2 days in a week, or maybe 3 days in a week, or 5 days in a week. Leflunomide, very useful drug. Use it as no loading dose nowadays. Earlier we used to give 100 milligrams loading dose in the day one, and then the 10 milligrams or 20 milligrams. Now straight away you can use 10 milligrams or 20 milligrams depending on the body weight. Fludarabine is not available. So NSAIDs, I told you something about the NSAIDs. You be careful not to use the NSAIDs left and right because NSAID gastropathy is very common. NSAID causing injury in the kidneys is very, very common. Steroids are very useful drugs. On the other hand, it's a double-edged weapon. So steroid causing complications are many. So as a postgraduate, you should know everything about the steroid therapy, ill effects of the steroid therapy. See, these are all the indications to cause the steroids, like crisis, the flares, the nephritis, in the neuro or neuropsychiatric, etc. So more good reasons to avoid the steroids. Hydroxychloroquine is a very important drug. Reduction the flares, reduction the organ damage, reduction the lipids, reduction the thrombosis, improvement in the survival, triples the mycophenolate mofetil response and prevents the seizure. See what else you require in a lupus individual. So these are all the indications or the advantages of the hydroxychloroquine. So please use it. But one thing is very clear, that at least once in a year, so get the ophthalmological examination to rule out any ophthalmological side effects. But fortunately, we are not getting any side effects of the hydroxychloroquine, even if you use 200 mg or 300 mg, 400 mg once in a day. Earlier, when the hydroxychloroquine was not available, we used it to write the chloroquine, your Lariago. So at that time, a lot of the side effects were there. So vitamin D, so definitely if you don't know anything, so please write vitamin D for all the population, whatever may be the disease. Like your gut microbiome, that could be one of the reasons for your lupus. So if you hear the recent Nageswarar speech, Padma Bhushan, Padma Vibhushan, so he is always, every disease is attributing to your gut microbiome. So lupus is not an exemption for that. So of course, vitamin D, now the one of the deadly dozen causes of the hyperglycemia. Earlier, so you have the omnious octet in diabetes, pathophysiology. Now we have the deadly dozen causes. So vitamin D is one of the other causes. So in the same way, vitamin D have a cardiovascular, intravascular, etc. Cytotoxic therapy, these are the important drugs. Immunosuppressive therapy is very important. So mild cases, moderate and severe react accordingly. So the biological therapies. So big thanks to our biology. You have the Erythematous, you have the rituximab, you have adalimumab, you have the tocilizumab. So these drugs are very, very important in the management of this lupus when the patient is in the flares. So now they are very available at the price of 7,000 to 8,000. Earlier they are available at the price of 30,000. Now big thanks to our farmer population, because of their competition, the rates of these drugs, biologicals have come down. So sunscreen is very important. Those people with the photosensitivity, topical steroids, NSAIDs, anti-malarials, hydroxychloroquine, steroids, cytotoxic, calcium, vitamin D, folic acids, and adult vaccination. So your influenza vaccination, pneumococcal vaccination, hepatitis B vaccination, zoster vaccination. So these are all very, very important in all these lupus individuals because these infections are very common in them. So the prognosis, so depends on your early diagnosis and because of your involvement with the drugs. Mortality is also very high, provided if you don't treat them. Complications are many, especially glucocorticoid complications like early cataracts, osteoporosis, etc. So your physiotherapy is also very important. So with this, I close my talk. See the different organs here. The lupus. Thank you very much for your patience.